So, good day, everyone. My name is Bjørn Erik Neerland. I'm a consultant in Geriatric Medicine in Oslo. I'm also a researcher in Oslo Delirium Research Group. And I'm very thankful to present this topic, interdisciplinary collaboration in delirium care, in this webinar. We know that optimal delirium care requires an interdisciplinary collaboration involving doctors, nurses, physiotherapists, and occupational therapists. And we also know that coordinating these interdisciplinary interventions may be challenging. So this talk will suggest and discuss some actions that can be taken locally, nationally, and internationally to improve the future interdisciplinary collaboration of delirium care. And this includes interprofessional educational activities, shaping attitudes to delirium across healthcare settings, raising awareness and knowledge in society and among healthcare personnel, as well as organizational approaches. So this is how it can be like to stay in hospital. This is a patient room with a view. It's taken from a bed in my hospital. And it shows very clearly that the surroundings are not familiar to anyone. It can be distressing. And if you also have impaired vision or don't hear what's going on, it's not very hard to think that you can start to imagine and to be confused about what's going on. So this is a distressing view. This is a better view, and it's the same patient room, it's the same patient bed, but something has happened. So I think what we usually want is to get from the pictures on the left side to the picture on the right side. And the question is, how do we get from the left to the right, where the patient meets a friendly nurse, is ready for mobilization. There is daylight, and the nurse helps with encourage to eat and drink. So if we go to PubMed and we search for multidisciplinary care or interdisciplinary care of delirium, this search will retrieve no results. And luckily, there has been written something about this the last couple of years, and I recommend this paper by Alessandro Morandi et al. And the objective of this paper is to promote the interdisciplinary approach in the prevention and management of delirium. So we don't find very much research on interdisciplinary care of delirium using these words. And the same is if we search in the guidelines we use. The search for physiotherapy or occupational therapy retrieves almost no results. However, it is very clear in the guidelines that we should promote cognitive engagement and introduce cognitively stimulating activities and mobilization. And they do suggest multi-component interventions for delirium. They don't use the professional groups like physiotherapy, occupational therapy, nurses, doctors, and so on. And we know that multi-component interventions are the best and most effective strategy to prevent delirium and the delirium-related items as falls in hospitalized patients. However, evidence of effect of non-pharmacological interventions in treatment of delirium is more uncertain. It's very hard to do such studies, but it is a tendency in most studies that this intervention was useful. And it has no harmful side effects. And I think most of us agree that there is still too much focus on drugs as the only solution in the treatment of delirium. There are always positive effects of good nursing and interdisciplinary care, also on other conditions than delirium. So it makes some kind of common sense to try to implement these non-pharmacological interventions also when it comes to treatment of delirium. I'll put up this list that you have probably seen before, and it's quite easy to put up this list of what kind of interventions and actions we should do in delirium prevention and treatment. We know that limited mobility is not good for the patient, so we should encourage the person to walk and do active exercises. We should keep the surroundings familiar and avoid moving the person unnecessarily. We should use clock and calendar and talk to the persons to help to orientate them, to let them know what's going on, where they are, what's the plan for the day, and so on. And we should be sure they have their hearing aids and glasses. We should make sure support is provided by carers who are familiar to them. Encourage them to eat and drink, and maybe also help them to eat and drink. We should avoid using urine catheters as far as possible. We should look for signs of pain, particularly if the person has dementia. This may be very challenging to assess pain and need some skills. And we should make sure that pain is well managed. We should avoid disturbing the person during sleep periods. We should review their medications carefully. And we should prevent and address constipation and be aware of urinary retention. So all these things together are about being delirium aware. And it's, as I said, it's easy to put up this list, but it's hard to do all these things perfect every time in all patients. And it needs more than only a doctor and only a nurse who is especially interested. So I think this is the solution. This is the interdisciplinary team in my hospital on my ward, consisting of a doctor, occupational therapist, nurse, social worker, physiotherapist, and also a nutritionist here. And in such an interdisciplinary collaboration, these groups are often involved. And in addition to the professionals, which should, in ideal conditions, have a physical environment that is appropriate for delirium care. That means it should be well lit with clear signs, single rooms as well. So we can simultaneously do diagnostic interventions. We should start acute treatment of the underlying conditions, and we should also start the rehabilitation simultaneously. I'll just list up some of the assessments and interventions and tasks for each that is natural for each profession. And for the nurses, monitoring of vital parameters, nutrition screening, pain assessments, promoting sleep and mobility, and assessing fall risks, elimination, social function, contact with the family, network, and medication administration. All these interventions are usually done by nurses, at least in my hospital. When it comes to the physiotherapists and occupational therapists, they are central in falls prevention and assess the level of function and the need of assistive devices. And they also help with mobilization of patients. They are essential in observation of activities of daily living, in the assessment of cognitive function, depression, sensory impairment, and they can also introduce cognitively stimulating activities. Interdisciplinary collaboration is also about to prevent complications by doing the best possible mobilization we can, up in bed at least, hopefully up in a chair, maybe walk. that is better for oxygenation, for mucus mobilization, and helping the patients to orientate better. We should ensure that they have as good vision and hearing as possible, and that they are able to functionally interact with the environment through ADL activities, meals, and maybe also games. So we know a lot of this. It's quite basic, it's essential, but there are obviously barriers and obstacles that we have to overcome and to improve this. And we can sort them out as organizational factors, professional factors, and personal factors. And if you have a look at the organizational factors, a lack of awareness, a lack of using the word delirium among the staff, using other words, agitation, problematic patient, the patient is not cooperating. These kind of words, instead of addressing delirium, is a barrier. We need to improve knowledge and skills, and we have to assess what is the motivation for culture change within our organization. How are the attitudes to care of frail older people, and how are the attitudes to collaboration, like in more general? And this is a paper illustrating this very good, and I recommend you to read it. Just another piece of paperwork consisting of focus group interviews with orthopedic nurses following hip fracture repair. And these nurses identified delirium as a very important issue and a multidisciplinary issue. They said they're so delirious that they don't want to eat, and mobility as well is delayed. The physio can't get them to do exercise with them. They also identified screening tool as a waste of time. They said, just another piece of paperwork really. Lack of time makes screening tool a non-priority. And they said that positive screening must trigger an action and that the whole team should engage. It's just a bunch of questions that you ask, and then what do you do with the answer? So they clearly expressed the need for a designated delirium care pathway. There's nothing worse than getting all these scores and all these things that you know are right, and tell the doctor and they're just, oh yeah, we'll look at it later. And no one comes back, no one follows it up, and it's frustrating, and it makes you think, why am I bothering? So I will point on some actions that each of us can actually do, no matter if you are a delirium expert or had never heard about delirium before, if you have influence on a local level or on international level. We can all do something. And I'll point out on organizational, and then on knowledge, and then on attitudes. Locally on the ward, we can identify barriers, we can identify obvious bad things that can easily be done better. We can introduce a delirium screening tool. We can ask about delirium status daily, and together with a interdisciplinary team, make a care pathway for patients at risk of delirium and with delirium. And we should ensure and ask for human and financial resources like single rooms, bisitters, etc. On a professional level, we need to increase our knowledge, and we should learn together as a multidisciplinary team, not only doctors and nurses and physiotherapists and so on, separate, but learn together in multidisciplinary meetings. We should use the daily rounds to teach the staff about delirium assessments, mobilization, that it is actually possible to mobilize patients with delirium, how to interact and communicate with a patient, how to comfort a patient, how to deal with anxiety, how to deal with agitation, and how to inform the family about this condition. We should use the MDT meetings to discuss hard cases. We should focus on and discuss non-pharmacological solutions also to difficult behavior. And we should identify and follow up underlying chronic cognitive impairment. These are nice topics to discuss in MDT meetings. On a more personal or attitudinal level, we should also engage with other professionals with other interests like falls or malnutrition, and show how you and others easily can make a positive difference. On a hospital level, we should use days like today, the World Delirium Awareness Day. We can use the intranet, we can give talks, we can write informational letters or flyers. We can get involved in making better hospital guidelines about delirium, be sure that they are easily available. We should try to influence on the leaders, and we should make delirium training mandatory to all staff caring for persons at risk of delirium. If there are any delirium experts in the hospitals, maybe some geriatricians, maybe some ICU nurses, they should be available, and we as delirium experts should offer teaching and training everywhere in the hospital. Use every opportunity to say something about delirium. We should identify and train delirium champions all over the hospital, and we should show delirium numbers across settings, especially to leaders, that it is common in the emergency department, in medical and surgery departments, in the ICU, and so on. And we should show the potential benefit of better delirium care. On a personal level, we should try to get there that all healthcare professionals has adopted delirium as being their responsibility. I would say that a delirium-friendly hospital is also a dementia-friendly hospital, which is an age-friendly hospital. And actually, good delirium care is good care for all. So delirium is not something special here. Good delirium care will benefit all patients in hospital. On a more national or international level, this day is a very good example of how we can use the social media. We can make websites and we can write in newspapers about delirium, informing and educating the population or the man in the street. We can make international or national interdisciplinary delirium interest groups. Organizations should put delirium on their agenda. Ownership at organizational levels is important, and we should ensure updated national guidelines according to best evidence. And we should try to get involved in policy making. On a more professional level, delirium should be a part of the curriculum in the various educational programs, both for undergraduate and postgraduate programs. We can organize joint conferences and teaching days and seminars for the whole multidisciplinary team. And we should encourage research collaboration between disciplines. When it comes to attitude, we should definitely combat ageism. And as I said on the last slide, good delirium care is good care for all. So all healthcare professionals need to adopt delirium as being their responsibility. They cannot say that this is something for the geriatrician, this is something for the nurses. So to wrap up, my message is that we need to get from here and to there. And I think the way we get there is to involve the whole interdisciplinary or multidisciplinary team. So my take-home messages for this talk are: optimal delirium care requires interdisciplinary collaboration. You can make a difference locally or in your hospital or even internationally, depending on your setting and your expertise. We should all identify barriers and obvious things, bad things that can be done better. We should get engaged with others, identify champions, find others that are interested in delirium, make a team. And we should learn together as a multidisciplinary team. There should be increased communication among scientific societies. And thank you very much for your attention. I wish you all a interesting and encouraging World Delirium Awareness Day. And please feel free to share this talk and also the pictures on social media. Thank you very much for your attention.